Howdy folks, welcome back to another lecture. In this lecture I'm going to talk to you guys about musculoskeletal and extremity trauma. So what are the parts of the musculoskeletal system? Well, the musculoskeletal system is composed of bones, muscles, cartilage, tendons, and ligaments. So all of these things in here make up the musculoskeletal system. So let's take a look at the skeleton. The skeleton helps support us against gravity. We have to have something solid so that we don't just turn into a ball of mush. So it helps support us against gravity. It provides movement and protection. The thoracic area, the ribs, for example, provide protection. The skeleton also provides production of red blood cells. So red blood cells are produced by the skeleton. And it's a storage site for calcium and phosphorus, which are two very important minerals for a lot of processes that take place in the body. So let's take a little closer look at some of the bones. Well, here we've got the bones of the skull. This is the skull. So up here we've got our forehead. It's in the front, so we call it the frontal bone. Here on the sides, this is the parietal. This blue one here is temporal. And back here is the occipital. This is the mandible. Mandibular joint is right up in here. The temporomandibular joint's right up there. Yeah, so those are the bones of the skull. So some important areas in the face. The mandible, again, is the fancy word for the jaw. The maxilla are the cheeks right here. The zygoma, or the zygomatic bone, is this back here. And the nasal bones are kind of right up in here. And you'll notice that this is it for the nasal bones. There's actually no bones here. Most of your nose is squishy cartilage. I'll move into the spinal column. So the spinal column, you can see it's actually a column of vertebra, of hard bony discs. And those are separated by soft squishy discs that help with a little bit of the shock absorbing of the spine. So the very top vertebra here, it is a cervical vertebra. So you can see right here it's cervical vertebra, C1 through C7. The very top one is called atlas. This is the one that actually really holds a lot of weight of the head and joins the spinal column into the skull. Axis is the next one down, and that is C2 right here. All the way down to C7, that's basically the end of your neck. The next one is the thoracic vertebra. And those are the ones in your chest, or your thorax, basically. And those are T1 through T12. Down in the lower back, you have the lumbar vertebra, and those are numbered 1 through 5. Down below that, you have the sacrum. Most of the sacral vertebrae are actually fused. And at the very end, you have the coccyx, which is the tailbone. And those are also fused vertebrae. So the thorax, as I mentioned, is your chest cavity, and this is composed of 12 pairs of ribs, and the ribs' job is to protect all of the organs inside. The ribs are held together by the sternum in the front, and then they do attach into the spinal column in the back. Some other terms to sort of know, this top part here is called the manubrium. It's a fancy word. It sounds kind of cool. Manubrium. And then down here would be very familiar with this one. This one's called the xiphoid process. Xiphoid process right there. Over along here, these are the costal angles. That's actually a useful term when you're trying to describe where something is, the costal angle. Next bone's the pelvis. This is a bony ring. So this is actually a complete circle. This is all joined together. I don't know if you guys have ever tried to break a ring, something that's a solid ring, but you know that you can't just break it in one spot. You've got to break it in 2 spots. So just keep that in mind. We're going to talk about musculoskeletal trauma in this lecture, and when you talk about pelvic fractures, they always break in more than one place. So they are 2 bones that are each made of 3 fused bones. You've got this area here. You've got the symphysis pubis here with the or sorry, the symphysis pubis is here. This is the ischium. This up here is the ilium, or the iliac crest is kind of right there, and that's the bony part that sticks out. So the bones are the ilium, the ischium, and the pubis. So the pubis is right in there. So lower extremities. So they start from the top of the leg, the thigh, which is also known as the femur. Here you have, so this is actually backwards. This is the backwards leg. This is the frontwards leg. In the front, your kneecap is also known as the patella. Your shin bone, the one that you can feel, is the tibia, and in the back is a much smaller bone called the fibula. Your ankle bones are called tarsals, foot bones are called metatarsals, and the toe bones are called phalanges. In your upper extremity, it has a very similar structure to your lower extremities, but a little bit different, and they certainly have different names. So the humerus, right here in the upper arm, you have the radius, which is on the thumb side, and the ulna, which is on the pinky side. You have carpals, which are wrist bones, metacarpals, which are hand bones, and the phalanges are the finger bones. So here's kind of another picture of all your different bones kind of put together. All right, so muscles. Muscles are important to allow us to maintain posture, and they allow us to move. They also do some other things that we don't necessarily have control over. For example, the heart. The heart is made completely of muscle. It's a particular type of muscle called cardiac muscle. Very specific. And you can see how in this picture over here it looks different from the skeletal muscle and the smooth muscle. So skeletal muscle, it's a striated muscle, so it looks like it has little stripes in it, and you can see that here. And that's just the way the muscle is structured. It just looks like it has stripes in it. Cardiac muscle is actually also striated, but we don't have any control over it. So we call it a third different type of muscle. Smooth muscle, however, is not striated, and it's something that we don't have any control over. It's an involuntary type muscle. Smooth muscle is found in a lot of different places. It's found in intestines. It's found in blood vessels. It's found in bronchioles. It's found in the uterus in females. And all of this smooth muscle is involuntary. We don't have any control over the movement of this muscle. So skeletal muscles, like I mentioned, are voluntary muscles. Muscles attached to bones by tendons that go across joints. So make sure you know what tendons are. Tendons attach muscle to bones. If you shorten the muscle, it moves the joint. I think the easiest way to think about that is you can actually take right now, put your arm out, and I want you to do a bicep curl. I want you to look at your bicep and feel your bicep. And you can actually feel that bicep shortening if you put your hand on it. So the bicep actually shortens up. You can feel that. And it moves your elbow joint. Smooth muscles, like I mentioned, carry out involuntary movements. They're found in the gastrointestinal tract, in the genitourinary tract, in the respiratory tract, and in blood vessels. So all the places we have muscle that we don't have any control over, it's smooth muscle. Cardiac muscle, it's a special type of muscle. It's found only in the heart. It has a property known as automaticity, which means that it can initiate its own contractions without any sort of external stimulation. It can beat independently. You can take a heart outside of the body and it continues to beat because it does it all by itself. As I mentioned before, tendons are the connective tissue that connect muscle to bone. Right there. Ligaments, however, connect bone to bone and they help support joints. They have similar presentations when they're injured to an injured muscle, but you may find the pain tends to be more sort of in the joint or near the joint, but it's hard for us to tell. Cartilage is another type of connective tissue. So cartilage is the thing that covers the ends of bones. So this is called articular cartilage or joint cartilage, and this is the knee right in here. You have the meniscus in here as well. Cartilage is also the stuff that gives structure to noses and ears. Joints. So joints are the joining points of bones. The bone ends again are covered with cartilage. Ligaments connect bone to bone, and the joint is between the connection of bone to bone. The inner surface of the joint capsules, where you have them, are lined with this stuff called synovial fluid, or with synovial membrane, which produces the synovial fluid, and that helps lubricate the joint. And we have different types of joints. In the skull here, we've got a fixed joint. Your hip and your shoulder are ball and socket joints. Your knee and your elbow are hinge joints. So that's our overview of the system. I'm going to talk now about trauma, extremity trauma associated with the system. So a fracture. The definition of a fracture is that it is a break in the bone's continuity. And you can see in this picture, this is a nice Colles fracture here going on. So fracture causes, you can have either a direct force, an indirect force, a twisting force, or a torsion. You can have diseases of bones, that we basically call pathological fractures, like osteoporosis, and tumors can cause fractures. Fractures can be either open or closed, and this is an important thing for you guys to know. Closed simply means that the skin over the fracture site is intact. Open means there is some sort of break in the skin over the fracture site. The bone ends do not have to be exposed. Even small openings in the skin that communicate with the fracture site mean that it's an open fracture. Open fractures are much, much more serious, in part due to external blood loss, but also very much so because of the potential for infection. You don't want infections to get into your bones. That's a bad place to have an infection. Here's a picture to gross you out. I think this is probably somebody's tibia popping out of their leg there. So this is a graphic here. This is a closed fracture because you can see the skin's intact, and an open fracture here. Bone's not sticking out, but it's open to the air, so there's potential for contamination and bleeding. So one of the most important things that we can actually do in EMS is prevent closed fractures from becoming open ones. Turns out when you fracture a bone, the bone ends are fairly sharp, and it's not difficult for those bones to kind of poke through the skin. So we do things like splinting to help keep the fracture from becoming open. There are a few different fracture types. So a transverse fracture, as pictured here, is where you have a fracture at a 90-degree angle to the shaft. An oblique fracture is a fracture that is at an angle other than 90 degrees to the shaft. And a spiral fracture is a fracture that coils through the shaft of the bone like a spring. There's also angulated, which means that the bones have gone at an angle. That first picture you saw had an angulated fracture. It may have also been displaced. I can't remember. I'll have to look. Let's go look. Let's see. Let's go back. Yeah, we have angulated and displaced. See, right in here. You've got it angulated because it's bent, and it's also displaced because the ends don't line up. So angulated and displaced fracture. There's another type. It's called a comminuted fracture. And this is, there's comminuted and there's impacted, sorry. Comminuted is where you have the bone is broken into more than 3 pieces. And an impacted fracture is where the bone ends are driven into each other. It's almost like a compression type fracture. And the last type is a green stick fracture. With a green stick fracture, the shaft of the bone is not completely broken. It's compressed on one side and it's splintered outward on the other. So splintered on this side, compressed on this side. So think about it. Which type of patient or which group of patients does this fracture occur in? Well, we call it a green stick fracture because it's relative to, think of young tree branches, the very young ones, very green. If you take and try and break one of those very green sticks, all it does is sort of splinter on one side and compress on the other. So this happens in kids. Young kids who haven't fully set their bones can get green stick fractures. All right, so that's the sort of the types of fractures. I'm going to talk a little bit about some patterns, I guess. This is a Colles fracture. I mentioned that slide at the beginning was a Colles fracture. It's a Colles fracture because it's got a fracture of the distal radius, although in that picture the ulna was also broken, so there's also an ulnar fracture as well. And what you get is kind of this fork-shaped pattern right here. Yeah, it looks kind of like a fork. Pretty obvious when you see them that it's a Colles fracture. Very obviously fractured. So you can see the deformity here, and you could gently palpate around and feel the deformity as well. So signs of fractures, deformity. If you see deformity, be sure to document that. That's actually kind of a big deal for billing purposes. If you document deformity, then for a Medicare claim, it's actually going to be paid out as opposed to not documenting it. So make sure you document that. It is one of the signs of a fracture. Tenderness. It usually hurts to break a bone. It's usually point tender, and it overlies the fracture site. So this is a key part of your exam. Oops, there we go. Didn't get that quite as pointed as I wanted. So the reason we do physical exams is so that we can find things like this. And if we have that point tenderness over a very particular area, then that's also something that's important to note. They're also likely to not be able to use the limb. This is a reliable sign of significant injury if it's present. However, just because they can use their limb doesn't mean that it's not broken. Some breaks still leave all of the muscles and everything intact. My little brother, when he was, I think it was 2 years old, he ended up with a green stick fracture. But we didn't really recognize it because he was still able to use his hand without a problem. He would just occasionally grab it and say that it hurt. So it was really a few days before they actually went into the doctor and got it x-rayed. And turns out he had a fracture. And that's not terribly uncommon, especially with the green stick fractures. So other signs, swelling and ecchymosis, which remember is bruising. Exposed fragments. If you see bones sticking out, that's a pretty good sign that it's fractured. Crepitus. Oh, crepitus. Oh, it's a terrible sensation. It's the grating of bone ends, and it's really more felt than it is heard. But it's one of those things that once you've experienced it, you don't really forget it because it's just this awful grating feeling. So it can be heard or felt, but do not actively seek this. It's uncomfortable for your patient. And it kind of might give you the heebie-jeebies because it's just, ugh, yuck. It's yuck. All right, I'm going to move into dislocations now. So dislocation is the displacement of bones from their normal positions at the joint. And this is somebody's shoulder. So their armpit's right there. And you can see there's clear deformity right there. This is probably, looks like an anterior dislocation, meaning it's dislocated to the front as opposed to a posterior, which is dislocated to the back. Dislocation signs are going to be deformity. This is going to be key here for you. Swelling and ecchymosis, again bruising around the joint. Pain and tenderness in the joint area. And loss of motion that's usually perceived as locked. And this is very true. These patients are usually not able to move their joint at all. It's locked in place. So wherever the dislocation actually displaces, it is stuck there. I'm going to point out a couple of these. This is a hip, either a dislocation, an anterior dislocation, or a fracture. And you can see this because he's sitting up. He doesn't have his foot turned out, and if you could measure, this heel is going to stick out farther than this one. So this one's actually back further. And I know it's hard to see that perspective here, but that is in fact the case. That the leg on the affected side is actually shortened and rotated outward. Some dislocations, however, will rotate inward. Those are actually really hard to do. So shortened and rotated outward is either a fracture or a dislocation of the hip. Sprains. Sprains are partial temporary dislocations. So you basically briefly dislocate a joint and then it just snaps right back into place. The problem is it results in some tearing of ligaments. The difference between a sprain and a dislocation is that the bone ends are not displaced from normal position. So you get no deformity. So no deformity with the sprain. Oops, sorry about that. I thought I fixed that. Okay, well, this says tenderness. One of the sprain signs is tenderness. This is swelling and ecchymosis. And this is, of course, inability to use the extremity, mostly because of pain. It hurts. It hurts really bad. I don't know if you guys have sprained your ankle or anything, but it is really uncomfortable. But there's no deformity. So, with sprains, the degree of joint dislocation at the time of injury cannot be determined during the exam, and extensive damage to the neural or vascular structures may have occurred. So, it's very important for us to make sure these patients go to the hospital for examination. Now, a strain, it sounds very similar to a sprain, but it has a T in it, so it is a strain, and it's a muscle pull. It's an injury to the musculotendinous unit. So remember, you have, your muscle kind of comes down like this, and then you kind of have it going into that tendon, which attaches to the bone, right? And so it's really this whole kind of unit here that ends up overstretched. It's really uncomfortable. There's pain on active motion, but generally speaking, the pain is not there when the patient's sitting still. So for your assessment for all of these, you want to, of course, perform your initial and primary assessment. You want to locate and treat life threats. And this can include femur fractures and pelvic fractures. Because if these are fractured, these are life threats. 2 femurs or 1 pelvis, or a femur and any other long bone, or anytime you have basically multiple long bones, like your legs or your arms. Those are significant fractures. You can bleed a lot, and that's really the concern with that. So we look for signs of bleeding with our primary assessment, and I don't think it's inappropriate for us to consider the fact that pelvic fractures mean bleeding. It's just not external. It's internal. Then assess, of course, for injuries of the head, chest, abdomen, and pelvis. And if we find anything, well, we're going to assess initially distal neurovascular function. So when we talk about that, you're going to look in the hands and the feet and basically assess for circulation, motor, and sensory. And this used to be pulse motor sensory. And we would abbreviate this CMS. It used to be PMS, and then some people got upset about that. So circulation, motor, and sensory. So circulation you can check by looking at cap refill or pulses, or both actually is best. Check motor. Ask them to wiggle their fingers, wiggle their toes, move their hands up and down, and move their feet forward and back. And then sensory. And ideally you check for light touch and then kind of that pinprick style touch, because they're two different receptors there. So light touch, so you just kind of run your finger lightly on their hand, and then pinprick, you take like a paper clip or a staple, a needle, and you just kind of lightly touch and see if they can feel that over a few points as well. So with the exception of pelvic and possibly femur fractures, and by femur it's really either bilateral femurs or any 2 long bones. So if you have a humerus and a radius ulna, then that's going to be significant. Orthopedic injuries are not usually life-threatening. And the reason that these are is just because of the associated bleeding. So don't let the spectacular orthopedic injury distract you from the ABCs, because it's the unobvious things that kill the patients. Maybe they have a really mangled broken arm, and you're so busy with that you don't recognize that they have a rigid, distended abdomen and they're bleeding internally. So don't worry so much about the orthopedic injury. Notice it, note it, and then do your primary assessment like you should. Come back to the orthopedic injury when you get a chance. So here's the thing. I mentioned the distal neurovascular function. Remember, neuro is nerve and vascular is vessels, blood vessels, right? So check the nerves, check the vessels. We want to assess pulses, skin color, capillary refill, sensation, and movement. We want to make sure that all of those things are present, and we want to be sure to document them. So splinting. Splinting is a great thing for us. Splinting prevents further movement at the site of injury. It limits tissue damage, bleeding, and, believe it or not, it really does help with pain when the patient is not constantly moving it. When you're in doubt, splint it. If the patient expresses concern that they have an injury to an arm or a leg or, a joint, then just splint it. It's going to make the patient more comfortable. It's really difficult for us to differentiate between fractures, dislocations, and sprains. So just splint them. So some quick principles of splinting. If you can, do not move the patients before splinting unless the patient is in danger, because if you move them, it's really going to hurt, and then why bother splinting at all if I've already hurt my patient? Remove the clothes to allow inspection of the limb. Note and record the distal neurovascular function, so CMS or CSM, if you prefer that order, whatever works for you, before and after splinting. So check it before and check it after. I want you to think about, why do we want to check it both times? The reason is that we want to verify that our splinting has actually not made the problem worse. If there's any wound, be sure to cover them with dry, sterile compression type dressings. That's not actually compression dressing, and a lot of times the splinting will help provide some compression. So cover it with dry, sterile dressings. For fractures, you're going to splint the joint above and the joint below the fracture. So immobilize, if this is a fracture, we're going to splint. Immobilize the ankle and immobilize the knee. For dislocations, you're going to splint the bone above and the bone below the joint that you're splinting. So if it's this knee, you're going to basically splint the femur up here and the tib-fib down here. For principles of splinting, you're going to minimize movement, support the injury until splinting is completed, and pad the splint to avoid local pressure. So we want to basically keep the splint padded. You can see these are actually called board splints because they're just padded boards. And then they've got a layer of padding around this to help distribute the pressure all over. And they've got this tied in a few separate places. So for angulated fractures, if you can realign it before splinting, then do so. We want to basically think the neutral atomic position. Neutral atomic position. Anatomic, not atomic. Thinking chemistry here. Anatomic. Silly. Okay, so the neutral anatomic position. And remember your anatomic guy. He's got kind of his hands facing forward and his feet pointing straight forward as well. So just think about that. If resistance or pain is encountered, stop and immobilize it as is. And you may have to get creative with this. For dislocations, you're going to splint as is unless circulation is compromised. You can reposition it once to try and restore the pulse, but if resistance or pain is encountered, then stop and immobilize it as is. And that's it for musculoskeletal injuries. And we're going to get plenty of bandaging and splinting practice. So bring any questions with you to class. Thanks.